I'm glad that most people appear to be back. That's good, because we kind of got a little confused, but we wanted to go on and get started back with our next section. Now, before we get into the health education and health literacy discussion, I have the questions that came up yesterday with Dr. Joy under the self-care issues. I have answers from her, so I'm going to share those with you at this time. One of the questions was, do you have concerns about meditation techniques in bringing up PTSD healthcare trauma that the patient isn't prepared to process? The response: meditation techniques and mindfulness strategies can be helpful for managing stress, so I don't anticipate these skills triggering most patients. There are always some cases that would be best to begin skill building with a licensed mental health provider. So if there are concerns for PTSD, please refer to an experienced psychologist or licensed clinical social worker with expertise in working with individuals with sickle cell disease. Okay, the next question. Are there any pediatric chronic pain rehabilitation programs with experience working with sickle cell patients on the East Coast similar to yours? Yes, there are many across the country. On the East Coast, Kennedy Krieger Institute, Cincinnati Children's, and Boston Children's have highly regarded pain rehabilitation programs. Next question. Could you elaborate on how a hot bath before bed is harmful? Because it works for me. Yeah, me too. To clarify, taking a warm bath may actually help increase relaxation and may be helpful for some a few hours before bedtime. However, taking hot baths, meaning higher temperatures, can hinder the sleep process. Some sleep medicine experts suggested that taking a hot shower or bath right before bed may raise your body temperature, which may disrupt sleep. Okay? And then one comment. Could we please circle back to the discussion about medical cannabis? I was interested in this too. This response was provided by my nurse practitioner, Wendy Webb. The CBD, yes, you can use for pain and stress management. We often recommend the 20-to-1 ratio for daytime use to help reduce the necessity of other pain medications. If there is an anxiety component and they are struggling with sleep, perhaps try 4-to-1 or 2-to-1 ratio of the CBD to the THC. For bedtime, tincture, gummies, and/or edibles are okay. We do not endorse smoking it. I'm glad she said that, because I was wondering about that. Remember, 1-to-1, just straight marijuana, and the TCH is the hallucinogenic portion of cannabis, which may cause other concerns. Okay? If you have further questions, please send a chat. We may not be able to get the expert opinion, but we have experts around, so we may be able to answer or at least share a response. All right. The next topic is we're going to talk about, in general, some principles about education and touch some on health literacy. Wisdom is not a product of schooling, but the lifelong attempt to acquire it. I like that from Albert Einstein. And is that not so true? And if we're talking about community health workers, you know, that's what we're counting on, is that expertise. One of my pet peeves, being that I'm a retired educator, did that for many, many years, is that people use the words education and learning interchangeably. They really are not. They're very different. And if you're planning and working and developing educational activities, you need to be aware of that and address that. Patient education is an activity to provide information. Learning is what the person or the patient does. All right? Kind of our thought for the day. Learning is what happens when what you thought would work doesn't. Have y'all had that experience? Yeah, I have. You think you know all about it and everything's going to be just fine. All right, the nature of learning, this comes from our literature and our evidence and our science and a lot of people that study this. And If you are an educator in any way and you've been in a master's program, you've studied all this in courses. You have whole courses. The nature of learning, though, and pulling it down to the three major domains: the cognitive domain, which is based on obtaining knowledge; the affective domain, which is the attitudes and the emotional part; and the psychomotor, which has to do with physical. All right? Let's talk about each one of those just a little bit in more detail. The nature of learning, or the cognitive part, is what goes on up here in the brain. It's a component of cognitive domain. It's the intellectual part of working and trying to do education. It's all about the knowledge, the comprehension, the application of that knowledge, the analysis, the ability to synthesize knowledge, and the ability to evaluate and in many different arrangements. The affective part is that emotional part. It involves changes in attitudes and development of value, the emotional aspect, the feelings. You've already found out that we're very interested in the knowledge part in SCCAPE 3. But guess what? We also have an interest in attitudes, and that's why we've done some polling and survey kinds of questions. And it's been very interesting to see what some of those attitudes are in regards to like racism and COVID. And if you're going to do an educational activity, you need to be aware of those attitudes and opinions because they affect your ability to impart knowledge. The other major piece, which is probably not as much in the world of sickle cell disease, is the nature of learning in regards to psychomotor. Psychomotor deals with the physical ability to do something. You all know that in doing like diabetes education, teaching patients how to do fasting blood sugars and how to give their insulin. These are all critical psychomotor skills. And so there's a different approach to that. Being an old nurse educator, major part of teaching nursing is all those attitudes and knowledge, but you got to learn how to do skills and go to the hospital and be able to do them. And so there's a whole component of that psychomotor, which is very important. We all learn with our own lens, and we learn based on what we already know. And as children, we learn things, and as we grow older, we build on that. Our belief system will determine a lot of what we learn. Our culture, we've talked about that on and off for the last 3 days. Our generation, and I'm going to talk about that in a little bit more detail in a minute. Our ability to relate to the information. For me, some of the information that, say, Dr. Lopato was giving, I can't really relate to that because I'm not in the clinic and I'm not observing that. I'm not personally involved. I can certainly obtain knowledge, and I have because this team has taught me a lot. But there's that certain ability to totally relate to the information. Now, the patients, different. I've had experience and worked with patients with sickle cell disease. So I can relate to that relatively easy. All right, and you cannot go through anything about education unless you talk about Maslow's hierarchy of human needs. And we've tested this out in the SCCAPE before, and we didn't test it this time on purpose, because everybody that's ever come to our conference has heard of this. But I don't want to forget it. And it's that whole principle that, you know, if you're going to try to educate somebody, but they're in the ER and they're in pain, you know what? You're not going to get very far because they've got to meet some of that basic psychological needs before they're going to be ready to listen and participate in a learning activity. So, factors that relate is a huge burden, and they're multiple, many of them. Needs, attitudes, your generation. It may be marketing. We have fantastic advertisers. We have people that charge a fortune to run 30 seconds of a Super Bowl commercial. And the folks in marketing really know about how to educate people and how to get people to do things. Amazingly so. We see that Coca-Cola up there, and that's what we go and buy at the store because we see that ad and we like that. One thing we've not mentioned a whole lot, maybe we mentioned it, is spirituality and religious beliefs. And it doesn't have to be just that somebody is Jewish or Christian or Catholic or, or Buddhist, but it also may be their spiritual life. Many of our patients have a spiritual life, but may not be affiliated with a specific religious group. So those are the kinds of things that can really impact how people learn, and then hopefully impact how we gauge and plan educational activities. All right, I purposely put this in, and the team kind of agreed that, there was a time back, I don't know, about a decade or so ago when everybody was talking about health literacy. Oh my gosh, And you know what? We've kind of drifted away from that, but we need to go back and talk about this, especially now, because a very good example of how health literacy has impacted our own politics around COVID-19. Health literacy is the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. All right, let's talk about this a little bit. Health literacy is not exactly literacy, okay? There's some slight differences. And this is a pretty busy chart, but it's something you may refer to, but literacy is certainly the ability for people to read, write, and attain knowledge. And I've learned too, not too long ago in talking with my nieces and nephew, that they didn't learn cursive in school. They're not teaching cursive in school. But that doesn't mean they can't write. They have learned to write, but we use our devices, do we not? So cursive writing has become not particularly useful and helpful, where in years past, you had to be able to write to get along in society. The basic probability and be able to work with numbers, and we're talking basic numbers, these are all part of literacy. When we get to health literacy, it's the ability to apply some of that number concepts to such things as reading a prescription label. So our patients need to have at least some basic elementary school level math, because they see that 50 milligram tablet or that 100 microgram thyroid tablet, and they can get really confused. And I bet you have seen patients, I have a husband, who doesn't understand, well, gee, if I've got a 100 microgram tablet here, I can just cut it in half and it'll be just as good. No, that's not quite how it works. Or that whole thing about, 75 is over here. So our patients don't necessarily understand, 2 tablets versus 3 tablets and what that all means. So we have to explain that to them. Years of school do not correlate with health literacy. I spent some time working in Northern Virginia, and if you know the DC area in Northern Virginia, there's many diverse populations. In the population I was serving, we had 51 languages that were being spoken, all right? And there were some very highly educated people in the population I was serving, because they were working in the embassies, highly educated. But when it came to American healthcare system and health literacy in the American system, they were not there. So I learned very quickly. I had to help them move forward in explaining how things work. So healthcare professionals are responsible for providing patients the tools to consume health information. This is our responsibility, okay? Health literacy affects about 12% of U.S. adults in our country. In other words, 9 out of 10 adults may not have adequate health literacy. So the burden is on us as health professionals. And a lot of people say, oh, we just can't do this because we're going to have all these. No, you don't need a lot of resources to be able to think about what's going on in the practice and in the setting, in the home, wherever this interaction is going on. that we need to be aware of the health literacy issues. So we've got 80 million Americans that have a significant problem with this. So we know we have patients within our population that have problems. All right, so why do we care about this? Well, a lot of reasons. We know that people that have low health literacy skip preventive health services, you know? They just don't know. They're less able to manage chronic disease. This has been highlighted and studied, especially in diabetes and heart disease. We know that they fail to make evidence-based health decisions. Now, we know that based on our experience with COVID-19. People are making decisions based on a lot of things, but not necessarily evidence-based health decisions. We are still hearing a lot of these mistruths and misinformation. And I think my colleague Ben's going to address that a little further. We know that there's an increase in preventable hospital and ED visits associated with health literacy issues. We know that a lot of Americans have less knowledge about their diseases, and guess what? It's costly. One study back, it was pretty long ago in 2007, said that there was anywhere from 106 to 236 billion US dollars spent because of health literacy. An updated figure that has come out extrapolating from those figures was that it's probably 1.6 to 3.6 trillion dollars we are spending in our U.S. economy on health literacy. That should make us stand up and think about that, because you know what? We can do something about this. Now, who is at risk? Well, I've kind of alluded to several of these, but some very specific groups are listed in the literature. Adults over the age of 65. I'm always doing this. Racial and ethnic groups other than white or Caucasian. Well, guess what? Our population is in that category. Recent refugees and immigrants. This is becoming even more important as we've had issues with our immigrant population and coming in from various places. People with less than a high school diploma or GED. People with incomes at or below the poverty level. And non-native speakers of English. So these are our high-risk groups. Some of those impediments to health literacy, besides our non-English speaking, or even those that English is not their primary language, cultural differences, and then one that has been mentioned is cognitive difficulties. Remember, I believe it was Ms. Walls, Rachel Walls, spoke of some of the I think even some of our docs, in that we know, and Dr. Sisler talked about some of the impacts and these hidden strokes that people have had, and that has impaired their cognitive ability. And so as a group of professionals working with sickle cell patients, we realize how it's important to do some of these screening tests and really be aware of that issue. Another concept that is tied to health literacy is this idea also of individuals that get so much information. Maybe at one time they get too much information and they get overwhelmed. You may have seen this in some of the patients you're working with, that something's happening and they're getting all this information and it's just woo, and you can see that that it's not just a health literacy issue, but it's a processing issue. But you put those two things together and we have ourselves a real problem. So how do you detect literacy? Now, Shirley has already alluded to some of this, but I'm going to kind of recap. Obviously, patients, they may have limited vocabulary, all right? And you know that because they don't ask appropriate questions, or the questions they ask are really not connected particularly. So we need to be aware. It may not be that they're stupid, it's just that they don't have the health literacy needed. Or patients that focus on details. They interpret things literally, and they can't seem to get out of the woods because of the trees, all right? You probably have some good examples of that. They may answer survey questions and not understand the meaning, so their survey questions are strange. And I know we have some researchers out there. I know I've got some researchers on this team. And unless you really pay attention to some of your survey questions, you may be getting strange results, and it's because your participants, even though they've agreed to the study and you've screened them, they still may have some health literacy issues and are not answering in an appropriate fashion. Or their inability to do simple math. And I think some of our community health workers, and I can tell you working with community health workers, not just in sickle cell but in other ways, had this problem a lot with patients totally misinterpreting how to take medications. Just really didn't get it, you know? Example, I found this one to be so true, and I saw it so many times in my practice, is a very cute is, I forgot my glasses today, so just give me that handout and I'll read it when I get home tonight, okay? That ain't gonna work. I'll say, so benefits of addressing health literacy are certainly looking at improved communication. We have better adherence to medical treatment. Patients' level of self-efficacy or empowerment will increase. Cost savings, because we said this very costly. Patient and provider satisfaction, which all of our big hospital systems, they're doing patient satisfaction surveys every time you show up for something. I don't know about you guys, but I get a survey, you know, and they want me. Now, what's interesting, if you hit more than 1 or 2 visits within a couple of weeks, all of a sudden you get surveys. And I got one the other day, and it didn't tell me, well, which doc, and I had seen 2 different docs and a nurse practitioner in the course of 2 weeks. And I went, well, which one am I supposed to be evaluating? And I don't know. So I didn't do it at all, okay? Individuals that have health literacy, or which we are helping them improve their health literacy, will feel more supportive and autonomous. And in that, especially with the goal of this conference, is that that's how we want people to feel: autonomous, empowered, and supportive. Now, there's a little technique, and Shirley mentioned it. I wanted to just kind of recap just a teeny bit here, is the teach-back method, which I'm sure many of you have already used. It's a technique to overcome literacy issues. And what it is a technique that asks the patient to repeat what they have just heard, but in their own words. Not just repeat just what you said, but get them to tell you in their own words. That's an important difference. And like motivational interviewing technique is one way to really help get at that. And it can be used very satisfactory. There's a digital handout in your virtual handout that is old, but it's excellent, and it goes over the exact steps on teach back. But a good example is if you have told the patient something very specifically. I need, you know, your medicine is prescribed to take 2 tablets in the morning and 2 tablets in the afternoon, or 2 tablets with supper, all right? And then you say, all right, just so that I can make sure that you're understanding me, would you please tell me what you're going to do with how you're going to take your medicines? And have that patient tell you, well, I'm going to take 4 tablets a day. No, let's go back and try again, okay? So teach back is a very nice little technique, and it's been used successfully for many years, and many clinicians, it's just second nature now. If you go and are going to have a surgical procedure, good places will be asking you to give back what you were just told in your own words. And if you're having a fairly complicated procedure, then that can get interesting sometime of what patients will come back with. So that's a good way to get that discussion going so that you know that the patient is understanding what's going on. All right, I also wanted to spend a little bit of time, I'm trying to be careful, all right, on the generational changes. This is fascinating literature to go to, and you know, this is not evidence-based, but it's observational-based. And a really good source is the Pew website, because they publish this stuff every year, in fact, so it's really interesting. I find this very interesting. I've had a couple of talks I've gone to where people have written books on the various generations. But let's just talk just for a minute, and you can probably look at this and figure out, well, where are you, okay? And that Gen Z that people talk about are actually the post-millennials. So, I was thinking the millennials were but you know what? We have a whole Gen Z that's after the millenniums. So they're born 1997 or after. They've been born in this digital age, okay? And they read less. Well, I should say they read books less. And they watch and listen more. So this is the generation that are so used to the digital world. They're on TikTok and YouTube, and they'll choose social media for their news. So Ben's going to pick up on some of this with the social media in a minute. So I'm not going to get into that. The net generation, which we don't hear so much about, were born from 1980 to 1940 to 2014, okay? These participants have always had digital media and access to the internet, but they've used the mobile devices to access and process information. So they're kind of that in-between group, so they're very familiar with it. These learners prefer augmented reality, such as simulations and virtual reality, and they want to construct information on their own. So this is kind of an interesting group. And then the Generation X, which I'm sure y'all have heard about, they were born between 1960 and 1980. All right, they tend to be very self-directed, like to work in teams, and may need to develop skills because they're not as likely to be as tech savvy as the net generation. So those Generation X are, now remember, these are not discrete categories. There's lots of overlap amongst these, but I just think it's fun to kind of look at the generational differences. And then we have the boomers. We all know about the boomers from 1946. Or 1940 to 1960. These, of course, were the boomers that were born right after or right during the World War II. They lived through some of the Vietnam stuff. Boomers, at this point in time, we see them, they're very accustomed to being very dependent on the teacher. They want the teacher to be in charge. They want to do a good job, they want to impress the teacher, and they prefer a caring environment. They want to be connected to the learning mission of the agency. So some of you may, if you're in this group, you may see yourself, all right? I'm going to get on over here. So in pulling from the literature, I made this chart, which I thought if you were interested, you can pull it up and look at it. And it really kind of goes down some very specifics. So if you were planning an educational activity, you may want to look to see who your audience is. Now, there was a group that I was working with that were community health workers, and they were all older. So I knew in planning that educational activity, there was some things I could do and get away with that I was comfortable with. But in another setting, when we were doing our original training here at VCU, which was in 2012, we knew we had to be more digital savvy. We had people in that group that were going to want the more digital kinds of things. So we had a lot of videos and workouts and breakouts and that sort of thing. But I heard a story, maybe it was Shirley that was talking, something, over this last 4 days, where there's some of our patients who we think are going to be digitally savvy, but are not. And they may be a little older, and if you're expecting them to go on some device and do something, forget it, because they're just not going to be able to do that. So looking at the generational gaps is probably a good thing to do, and really look at your audience and figure out where you need to fit in. But these are not discrete categories, so you can't draw conclusions. But I thought that chart may be helpful if you were going to devise some training. Okay, the internet factor, I'm not going to get into this because I think Ben is going to really get into it very interestingly. But we all know that more and more and more people are using the internet to get their health information. And this, here again, the Pew website really tells you about that. And that has dramatically changed over the years. And guess what? It wasn't that many years ago that we talked about us boomers and us silent gen, those of us that are older than even the boomers, we weren't going to have anything to do with the internet. Well, guess what? That has already shifted and changed. Many of your boomers and over that age group are now using the internet and on a fairly regular basis. So we have to be aware of that. All right, internet assessment. Now, I'm going to say this because I know Ben is going to allude to it, but we as the professionals and the teachers have got to be aware of that internet use, all right? So I want to go over a few things. And we need to teach our patients about that because we all know, especially now with the misinformation that's been all over the internet and the apps and all over the place, we've got to teach critical analysis of what's on that internet. I know myself, I've gotten on the internet, and it's very easy to get on some very interesting sites that are not appropriate, okay? Very quick. I have a husband who loves to get on the internet, but oh my gosh, he can get some crazy stuff. And I'm like, where did you get that? And then I go find out where he got it, and I'm like, oh, okay. There's a couple of things. We definitely want to know who said it, where did the facts come from? I'm slow on this. I'm sorry, I get behind. All right, who said it? Where did these facts come from, if they're even facts, okay? Who paid for it? I think that one's really critical. You know what? And that's hard to find on an internet site sometime. You know, who is sponsoring this? Who's put this together? So I know even Dr. Smith, when he was sharing some information the other day, he talked about, you know, here are the good sites to go to. Go to NIH about COVID. Go to the CDC website. Another one that's good is the WHO, even though you got to be careful because that's global looking. But some of these other websites, you know, you got to look at who's paying for it. When did they say it? And those of us in healthcare know how important that is. Just because somebody said it in 1958 does not mean that it's relevant in today's world. And then how did they know? All right, I know that a lot of you are participating in a lot of different podcasts, and I've been on some, but there have been a few that I've been on that I sit there and I listen and I listen. I go, wait a minute, who is this person? And where are they getting that information? I mean, I was listening to one because I've been really trying to work out and eat a healthier diet and try to lose some pounds and, you know. And I was on this website and they were talking about healthy protein and all that. I'm okay, this is what I've heard, All of a sudden they start talking about, well, you can't eat cheese because cheese goes right to your thighs. And I went, what, wait a minute. And then I go back, well, guess what? It was some podcast from an actress who has no knowledge of nutrition. She has no background in nutrition, and she didn't even get her information from dietitian/nutritionist. And I went, oh God. So I got off of that. It was like you can get caught into these digital platforms, and you've got to be critical because, you know, I don't know about you guys, but it's really easy to get caught up, and you can spend hours messing around on these websites or podcasts. All right, so as a professional, though, working with our patients with sickle cell, we have to start thinking of ourselves as a partner with our patients and helping them to think and look critically at the information that they're obtaining, okay? So, and I think this is where our Sickle Cell Association is, and I know and I've gone on the internet just to look at all the different sickle cell foundations and websites. And there's some really good ones out there, but there's a few that I'm like, okay, I'm not feeling real comfortable here. So we, even in the sickle cell world, need to be careful as to what is out there. Now, if we were getting ready to train a group of community health workers, because we're going to bring community health workers into our medical care team, which we've been talking about. If we were going to design an education activity, many of you already know this, but some of you may not because you're fairly new at this, all right? We heard from some people the other day that are really working around this, or they haven't been in the field that long. Designing an educational activity takes lots of forethought and lots of planning. You must set goals. You need to write objectives out of the wazoo, and you need to decide on your teaching methods. I've alluded to that. And in today's world, you need to look at generational gaps and look at your audience and who are they and what's their age and how do they learn better. And then the big one that we tend to forget or just ignore is we need to plan our evaluation from the get-go. We plan our evaluation the moment we start planning our educational activity. The first step in any kind of educational activity we're doing. Now, if you're enrolled in an academic center, you go, well, nobody ever asked me what I want to know, but in reality, they have. If you signed up for that course, Statistics 101, somewhere you have figured out, maybe it was because you needed it to get your master's degree, but you have a need. So therefore, somewhere in there, you have a reason to be there. For our patients that we're working with, we have to figure out what it is they really want to know. You're talking with them about the fact that they may have to have their spleen removed. That's a pretty significant something to talk with them about. So we got to figure out what is it they want to know, what do they need to know, what is their readiness level? Are they at a point that they can hear the why of that? So that's part of what we have to do. What can increase a person's motivation to learn? Why is that important? And what is the priority? How does it match the person? So being patient-centered is really, really important. And we've mentioned that several times the last 4 days, have we not? Goals for health education activity really should be a partner with the participants, the patient in this situation. Ideally, it should be driven by the person or at least shared, because we know sometimes we have to impart knowledge and we have to get that patient on board with where they are. And it may have to happen quickly. And it should be, a goal is very broad, okay? Very broad. Okay, objectives. I would love to be able to do a quick survey, but with our technology here, if you were here in the audience, I'd say, how many of you have written SMART objectives? And I bet you a bunch of you would put your hand up. And I'd probably find several of you that go, what in the world is she talking about? If you live in the world of grant writing and grant giving, which I did for 26 years, writing grants, getting grants, administering grants, all right, you have to be able to write SMART objectives, especially if your grant is coming from CDC or HRSA, and for most of the foundations. Now, NIH, they're a little different, all right? But CDC and HRSA, I know from being there. And they talk about, and so SMART objectives are S, specific, M, measurable, A, achievable, R, realistic, and T, time. So what in the world does all of that mean? Well, specific is it has to be specific and what the change or the improvement, the change of behavior you intend to have come about with this educational or this activity. M, it's got to be measurable, but I do not mean that you go in and count calories or you count observations or frequencies, okay? It's all right, if I understand something, I understand how sickling occurs. Do you know that by looking at me? No, not at all. So how are you going to communicate an objective that you know that Joan actually knows something about that? Well, you got to write an objective that means that. So it has to be like observable, something you can see me do, and that can mean talk, okay? And a lot of what we do in education is either through test taking, talking, all right? And then A, achievable. It's got to be something you can attain in a reasonable amount of time, all right? So A, R, T are very connected. It has to be reasonable. All right, before we get to, I'll show you an example. Bloom's taxonomy is something that's been around for a lot of years, and if you in academia, you know all about Bloom's, taxonomy, and don't you just love this? Very, very busy, and that's all right because it's a slide. But it's the little staircase, all right? And what that's trying to show you is that you start with the easy stuff and you work up to the higher level, harder stuff. More specifically, I'm going to give you a couple of hints. If you're writing an objective, you're going to do an educational activity. You want to impart some knowledge, right? Well, if I'm imparting knowledge, that's very passive. That's not student-oriented or participant-oriented, all right? But there's knowledge you want your audience to have, right? So words like, I'm giving you a couple examples here. I call this my little cheat sheet. Just as that stair stays is a cheat sheet. If you're talking about knowledge, all right, you can look in our materials here, and you will see a lot of knowledge kinds of objectives. You're going to define something, you're going to list something, you're going to record something. So it's those words that have meaning and that I can observe, I can measure. Like all of you have been in school in some way and you've had a test. Well, that's what a test is most of the time, is assessing your knowledge level, because you're spitting back information, all right? The comprehension part is where you not only are spitting back information, but you can use that information. So you do things like translate, discuss, describe, debate. You'll see those words a lot in curriculum design. A good example that when I was teaching, I'd write a scenario in the test question, and then I'd put answers there that were showing that the person who was looking at that scenario could apply that knowledge to give me the next best. Some of your pre-test and post-test are written exactly like that. You probably could go find them. And that this is the situation. What would be the best answer? What would be the first thing you should do? What would be, all right? Now these are hard to write, I can tell you, because you got to, coming up with erroneous answers is very difficult. I can tell you from doing a lot. Application is then that next step. Do you not only comprehend the information, but you can look at it, you can use it. For those of you that are clinicians, you have to know about, let's say, the depression screening scale. You have to understand what it's doing, why it's doing it, and why you want that patient to do it. But the next level is that you know how to give it, you know how to interpret it. So you can see the different gradations of how you would learn something. So if I'm a teacher and I'm teaching my, say my clinician to use and administer the depression scale, what is it, PQH-9? We even have that in the virtual handout, by the way. Then there's several levels of gradations that I would have to learn in order to do that appropriately. So see your virtual handbook. There's a whole little handout on how to write objectives. It's there, so you're free to use it at will, okay? And I think I put references on there that you can even go. And then depending on what you're doing, like in all the grants, they all want to know your short-term objectives, and they want long-term objectives. So this is certainly something immediate versus something that in 2 years this is going to happen. And it gets interesting when you're writing grants, how that goes. So just a little exercise, and we're not going to belabor this. All right, Mrs. Tamika Bowles is a 42-year-old patient with sickle cell disease. She admits she has not been taking her hydroxyurea regularly because I just cannot remember. Okay, take just a few moments. Jot down what you think would be a valid, smart objective if you were going to be the clinician that is now talking to Mrs. Bowles. Just take a couple of moments here. Doesn't have to be pretty. What would be a smart objective? Okay? If you didn't finish, that's okay. Nobody's going to see this. Look at what you wrote. I've written one. By the end of this client-provider conversation, Mrs. Bowles will verbalize one strategy she will use to remember to take her hydroxyurea. So here are my criteria. Is the intent clear? Yeah, pretty clear. Is the behavior observable? Yeah, because it's verbalized, so she's going to speak it back to you. Attainable? Yeah. We don't know whether she'll attain it or not, but it is attainable. It's realistic. Is it relevant? Oh, very relevant to her care. Is there a time frame? Yep, by the end of your session with her. All right. Now, you're not going to be writing objectives quite this down in the nitty-gritty, in the weeds for anything, but I think it helps show how this can happen. All right, so teaching methods, I've alluded to this. We need to include all kinds of factors: age, gender, culture, generation, developmental disabilities, special learning needs. We talked about our sickle cell patients may have cognitive impairments, educational level, health literacy, knowledge of the subject. So yes, we have all kinds of different methods. All right, adult learning theory, we have mentioned this a couple times, and if we're doing anything, now, Dr. Sisler is in the pediatric world, so this is going to change a little bit, not a whole lot, but adult learning theory is really the cornerstone of CHW curriculum design, because all of those folks have experiences, they have knowledge, they come to you with information. What you may have to do is apply everything to what they already know so that it has meaning for them. So adult learning theory is really important to us. Audiovisuals, absolutely critical. And we need to use the audiovisuals freely, but we need to scrutinize for appropriateness, and we need to know what is already out there. That means we got to do our homework. And periodically, and when I was in practice even, I realized very quickly, and we didn't have the internet and some of the stuff, the social media, when I was doing direct patient care and as a nurse practitioner. But I learned very quickly we did have the internet. I had to get out there and find out what was out there, because I needed to be able to say to them, you know what, here's a good website over here. Let's maybe not use that one. All right. The print materials, this is one of my buggaboos, and so I'm not going to harper on it, but we all kind of know, but sometime I think we need to be really aware of our print materials. We need to use active voice. We need to personalize it. We need to avoid slang and jargon. We need to use plain language. You need to use a nice big font. No, and we don't need to put all in uppercase. Have you ever seen that? It drives you nuts. It's hard to read. You need plenty of white space. You need to break up your text. Use bullet points. And one of the, I think the biggest piece of which at the health department we dealt with this a lot, all right? We use social marketing concepts, and so everything we published for the public in the educational realm, we test it with our target audience, okay? Critical. You need to have your target audience give you input. Otherwise, you can build beautiful brochures and they will be worthless. A little exercise I used to do with my nursing students was I'd get them to bring brochures from all the clinics they were out visiting. I say, pick up some of the brochures and bring them in. And then I sat them in a classroom one day and I had my little criteria and I said, okay, I had little groups. Oh, they had a ball with this. I want you to evaluate this brochure using these criteria. And they would discuss, and oh my gosh, so much insight, because they would go, oh my gosh, this is terrible. It's not at the right level of input, you know. It was at like college group, and here they were out in the family planning clinics. I mean, it was just interesting. And things like plain language. We do this all the time in our academic, in clinical settings. We talk about stuff because we all know what it is, but our patients don't. We talk about PO. What in the world is that? By mouth, you know. Using words like, I don't know if you've ever had things like, we talk about the poor workers. Well, are they poor because they don't have money, or are they poor because they don't do their job very well? See? So we've got to be very, very critical of what we use. So you could take this checklist and go back and look at some of the things that you're doing and maybe take a little step back and look at it and see maybe you need to maybe rework it a little bit. I've got tips for health education. I'm going to skip that because they're written there. Scheduling, again, when you're planning an educational activity, you've got to have building blocks and you've got to move up the chain. Kind of like, remember Maslow, remember the staircase. And most things are learned better sequentially. And then I cannot stop and not say, let's not forget the evaluation. It should be a quality, continuous process. Just as SCCAPE, we know we did it back a bunch of years ago, then we came, we did it, and we reevaluated, we looked at it, we brainstormed, we redid it. We have redone this thing, and we'll do it again, and we'll use your input to evaluate and hopefully meet our folks better. My closing thought, I thought that was kind of cute. I am going to learn to relax. Have you ever said that to yourself? Even if I have to work at it 24 hours a day, 7 days a week. So we all learn differently, but when we're planning an education for our patients, we have to understand and learn about educational principles of how we go about doing this.